I have to say I was a little surprised to hear that I'm supposed to give a 3.5-hour talk here. So I'm glad we had some lunch. Everyone settled in. I'll just keep moving along. Should be fun. So I'm Ed Smith. I'm a neurosurgeon over at Boston Children's, and I really, it's an honor to speak here today. I will say that I give a lot of talks, and while I usually feel pretty comfortable talking to folks, it is, I think, the most humbling to speak to patients and families. So, it's easy to talk to a bunch of nerd doctors, but it's a little tougher with families, and I hope that folks will be candid in asking questions. I was asked to talk today a little bit about the sort of overlap between Act 2, Moya Moya, and neurosurgery. And in the grand scheme of Act 2, this is probably the tiniest slice of the pie in the Venn 2 my diagram. So there's not a whole lot I have here to say, and it's nowhere going to be as interesting as Patty's talk, but I'll do my best. I have no financial disclosures to make, but I do have the disclosure to make, which is no one really knows exactly, what Act 2 Moya Moya is like. The question I get asked the most is, well, what the heck is Moya Moya? So in facing the group here and in thinking over how to do my talk, I decided to go to the most definitive authority I could possibly think of. We have some really smart folks here from Texas. You got Mass General, you got Harvard Medical School. So I resourced all those things, and I went to Wikipedia. And so, the Wikipedia definition is Moya Moya is a disease when arteries in the brain are constrained. And like my wife says to me on rare occasion, you're not wrong. But I thought I would start talking a little bit about what Moya Moya is in general and use that to lead into what this blood vessel disease is that we see with Act 2. So starting with regular, if you call it regular Moya Moya, it was first defined in the 60s as an X-ray disease. A bunch of doctors were sitting around, they took some X-rays, and they saw that with X-rays, this is an X-ray of the brain, this is sort of her broccoli brain that Patty showed before, and these are the blood vessels coming up into the brain, and this is a normal brain right here, and then what happens is, just like traffic on a Memorial Day afternoon in Boston, the blood vessels get smaller and narrower. As they get narrower, not as much blood goes up into the brain, and over time, just like if you're driving through downtown Boston and the main highway gets shut down because it's too tiny, cars will go off on the side roads, and they'll get all the little side roads, and they get congested, and they fill up with this side traffic. And this so-called puff of smoke is basically all the blood getting rerouted. And we'll talk about in a minute, you saw Patty's slide a minute ago, how that this is different in Act 2, but this is regular Moya Moya. But the shared problem is ultimately there's no good blood supply to the brain, and that can lead to the risk of stroke. So people saw this on X-rays, just like the X-rays with Act 2, and they said, well, this is concerning. And then they got a step further, and they got a little smarter, and they decided to look at the pathology. And this is where there is some common overlap, where if you look at the blood vessels and you take a section of them, like a slice through a straw, and you look at the blood vessel in cross-section, parts of the blood vessel grow too much. People talk about how Act 2 is a disease of smooth muscle cells. And smooth muscle cells line the blood vessel like a radial tire. And if these blood vessel cells grow too much, what happens is it's like putting bricks inside of a tunnel. You keep building the walls in and in and in until the inside of the tunnel, called the lumen, gets too tiny. And that's where you see, I'm going to try to take my eyes out here with this laser beam thing. That's really helping with my surgery later. I'm sure there's a button somewhere. I've been clicking this and some lady's switch in Kansas says stop doing that. Oh, green, right, that's... Yeah, this is what happens in the OR, I just showed okay, that's good. Great, what could go wrong? So this is what people are living off of. That little white spot right there is the blood supply to that part of the brain. And you can imagine that that's a real big problem, and as folks mentioned, one of the reasons we talk about aspirin is that if traffic is slow, just like if you have really thick traffic on the highways, you're more prone to getting accidents. And if you have really slow blood flow in the blood vessels, because they're narrow and congested and all the cars are bumping up against another, like all the blood cells are bumping up against one another, there's a greater risk of them whacking together or sticking and causing clogs, which is what you see here, a little clot, and that'll stop blood flow. So we think aspirin can help with that. What's different about so-called regular Moya Moya And ACTA 2 moya moya is the same slide that Patty was kind enough to share before. Here's a normal set of blood vessels here coming up, so this comes up from the neck. Here's the broccoli brain tree here, if you will. And with ACTA 2, this gets kind of fat and chubby, and then it just kind of stops straight right there. So it's like a 10-lane highway goes down to a 1-lane highway. And then the blood vessels in the brain are different too. They don't have the little squigglies, and there's no puff. The fancy doctor term, apuffia. No, I'm just kidding. ACTA 2, if we call it ACTA 2 moya moya and so-called regular moya moya, they're different diseases, but they share some common themes, and you know, it's important to recognize that. The ACTA 2 is different, as Patty said. You got this narrowing right here. You don't have the normal bends and curves of the roadways. They're all pretty straight. Disease in kids and adults that have ACTA 2. And this is really hard. There's only about 60 cases that have been reported in the literature of the vasculopathy that have been sort of written up. There's more than that out there, but this is what's in the literature. And if you look at them, there's only been about a dozen or so cases that have been reported. We've had a few more here at Boston Children's. There's been a few more at other places. But basically, they're about half and half between those that get good results and those that have some very bad outcomes. And as a surgeon, it's very, very humbling. And you know, we've had some patients that they thought technically the surgery went great and they've had some very sad outcomes. We've had other ones that have done wonderfully. And it really is awful hard because I don't have that crystal ball to tell the family who's good or who's not. And this is where it's so important to have these kind of groups. And I really applaud everyone here for working to create this so we can get these answers, maybe figure out a little bit better who are the right folks to operate on and who are the folks we should potentially be alone. What do we know so far? What's the bottom line? Well, if we can get you through the surgery without any complications during the surgery or for the first couple of days thereafter, we think it probably helps. Although, again, that's a point of debate. But the surgery is very risky. As you saw, there's a high rate of perioperative complications. And some of the things we're trying to learn is, can we figure out who are the right folks to get surgery? Some folks, I think, should be coming to see us and getting surgery. Other folks should run away and maybe not have us touch them. We've got some intraoperative monitoring, brainwave monitoring during the surgery. Can we get better at this and figure out how to do it? And can we figure out ways to better control blood pressure? Because as Patty mentioned, getting that blood into the brain, especially the blood vessels are unhealthy, is probably a really important way to reduce the risk of strokes during that fragile period of the surgery. So that begs the question, all right, Ed, if we figured out this, how do you treat the patients? What is it that you actually do? And I hear this a lot from the patients when they come in. They say, all right, doc, they've maybe recommended surgery. What the heck's going on? And so one of my goals today is not just to define what sort of the surgical aspects of moya moya are, but what do we do about it? And so basically the operation, I thought a lot about the traffic idea, and specifically this weekend here in Boston. But here's a little map of Boston here. We're right about there. And suppose that we're down on the Cape and we want to get up through Boston to get to New Hampshire because it's going to be hot this weekend. We don't want to get eaten by sharks down here and get cod. We want to hide up in the mountains. So if we want to get on the road and drive up there, it's kind of that same idea like moya moya and ACTA 2 or other types of moya moya, where this is an X-ray, an angiogram looking from the front, kind of like this. And what you can see is that the normal blood vessel comes up and then it gets choked off right here, whether that's ACTA 2 or other moya moya, you can't get to the brain. And that's exactly like Boston. If you're trying to get from the Cape up to New Hampshire today, it ain't happening. You get stuck in the Sumner Tunnel or you get stuck in the Tip O'Neill Tunnel and it doesn't work. So what can we do to make that better? Well, we know that a lot of the blood vessels on the scalp are healthy. They're fine. They don't have this funny blockage here. And if we can get healthy blood vessels from outside the head, somehow through the bone, like my wife says, sometimes you got to get that through your thick skull head, surgery can create a new route around the obstruction to bypass the sick area and get the blood vessels where they need to go, essentially taking Route 128 and getting up to New Hampshire that way. So that's really what I am as a surgeon. This is a traffic cop or a plumber. It's not much too exciting for what I do. But that's really the crux of it. You don't fix the underlying blockage inside the head, that little narrowing I showed you. We just get new blood from other places that are less affected and bring that to the brain. And so I thought I'd share a little bit about what that is. My mentor, Mike Scott, who since retired from operating, but really was amazing at this, is he helped develop a variation of the surgery that was first found in Japan, where you take a blood vessel from the scalp, you move it out of the way. I'm going with another traffic analogy here, but just like the big dig, we remove a piece of the skull and you run it down underground or under the skull, just like the big dig runs the highway underground under Boston. And the idea is that that big dig, now we've removed this barrier to the brain by opening holes in the skull, and that blood vessel goes down and it digs roots into the brain. And what's unique about what we do with kids and kids with active 2 is that we open the lining of the brain so that all the growth factors, all the proteins, all the chemicals like fertilizers that make blood vessels grow can help stimulate this to grow. And we sew this actually to the brain and it grows over time. In some ways, it's a very beautiful surgery because it's a natural biological program. And this surgery, all we're doing is we're like midwives. We're essentially letting nature take its course and just facilitating this entry to let it do what it's supposed to do. Now, the next thing is I have a little spoiler right here. I have a video of one of the surgeries that we do. And I know some people don't like to see it because it's kind of gross. We actually have Moya Moya Day next week over at Boston Children's, and families love it. They ask for it most years. So I'm going to show a video of surgery, unless, and if people don't want to see it, I would advise you maybe to check your smartphones now and play Words with Friends or InstaChat or Snapgram or whatever the cool kids are doing on their phones right now. But this is, you know, I think it's important to understand what it is we do. And so this is a little baby that came to us. We're putting these brainwave monitors on during the surgery. And just to sort of talk you through what the surgery is, a couple of minutes here. But once they're asleep, the kids don't feel anything, so there's no discomfort for the children. We map out this healthy artery on the skin with an ultrasound, so we can hear where it is. It's right in front of your ear, you can feel it. We then, under the microscope, open up very carefully under here, and this artery is about half the size and the thickness of a strand of spaghetti or a really thick piece of string. And we open this up along the way, and this is, again, if you put your hand right in front of your ear, you can feel that artery pulsing. It's called a superficial temporal artery. Just want to impress people at Yahtzee tonight or your, Barbie, you can do that. But this is a healthy blood vessel. This doesn't have, while the whole body has active 2, this doesn't have that same thickness that the carotid artery does. And we can get this out, and this is laying on top of the chewing muscle called the temporalis. So put your hand here and you're chewing gum right now, or you're gritting your teeth like, oh gosh, I don't want to see this. That's what this muscle is. And we free the artery up, and we get a bunch of tissue around it, and we open up a little flap under the skin. So this is the chewing muscle. The nose is over here. We're cutting the chewing muscle here. So the ear is down here. The nose is here, and we reflect the muscle back. This is the bone. And what we're doing, this is the real key part here, where we open the bone and we remove this window of bone. This is the lining of the brain, the dura. And we open it up. You may have heard of meninges, like meningitis. And this is sort of getting rid of all these layers that are stopping the good blood vessels from getting rid of needed. You can see we're opening this up now, these little flaps. Here's the brain, and you see how the surface of the brain is so angry, it's just starved for oxygen. And this final layer here is called the arachnoid. It's like a saran wrap layer, shrink wrapped on the brain. And we spend some time carefully trying to open this up over the natural blood vessels of the brain so that we get rid of all these barriers from the outside to the inside. And by opening this up, we can let these sort of blood vessels that are hungry for blood, that downstream have that traffic blockage. This is like the roads up in New Hampshire. Here's our new healthy blood vessel that now can get to the brain where it's needed. See, the brain's all red and really starved for oxygen. With this blood vessel, we take this little tiny suture. This is about a third the thickness of human hair, and we sew this into the brain itself. And the idea is that if we stick the blood vessel to the brain and we sew it together, even with heartbeats and as the brain is moving a little bit, it will stay close together. And just like if you're grafting a branch onto a tree, over time, the proteins and the chemicals in the brain, this is what we're trying to learn about what these are in the lab, they will stimulate this blood vessel to sprout branches on either side, just like a second grade science experiment, except that this is real life and it can genuinely help people by growing these blood vessels into the brain so that this makes connections to these, and this is the new lifeline. This is your new big dig project, bringing blood into the brain, and along with this lining of the brain, we just close everything back up. This is some gel foam, and one of our hopes in the future is to implant proteins here that might make the blood vessels grow better. We're putting the bone back on, we sew everything up. These are all dissolvable stitches, and at the end of the day, the hope is that this is what we use. It takes about an hour and a half or 2 hours, and the hope is that this will help people. These are some pictures that Patty gave us, and what you can see is this is a before X-ray picture. And what we're showing here is that these are the natural blood vessels, and you see that the highway comes up, it's clogged there, and there are parts of the brain that are really starved for oxygen. There's really no blood supply there. And those are the parts of the brain that are at risk of having a stroke. And these are the blood vessels on the scalp, the ones that we would harvest, and you see that they're not connecting to the brain in any way. After surgery, you see now, before where there were these gaps, everything is full. The whole brain is kind of full up of what we call collaterals, these surgical blood vessels. If you just look at the outside ones, where we've implanted them now, these grafts, they've grown roots. So we're filling up these empty areas now with surgery. And so the brain in ACTA 2, these are ACTA 2 patients, will grow blood vessels. The big question is, and I don't think we have enough data long term, is do these blood vessels do a good enough job of preventing these strokes down the road? And that's really one of the question marks that I hope that we can answer by working together here, but that's what's what. Another type of surgery is called the direct bypass. And in this case, instead of laying a blood vessel on that can grow over time, and the disadvantage there is it takes weeks or months for those roots to grow. The advantage is you can do as big of an area as you want. The other way is this direct one where you actually cut a blood vessel, you sew it into another blood vessel. So you get blood instantly, which is an advantage, but there's a much higher risk of causing bleeding or side effects. And also, you can only plug it into one part of the brain, and the more pipes you put in, the greater risk there is. So there's advantages and disadvantages to both. This is a live surgery picture with glow-in-the-dark stuff. You can see the blood coming in here, and now it will fill the brain up, showing that this bypass, we connected the graft vessel to the brain, is now able to fill the brain up instantly right at the time of surgery. And this sort of glow-in-the-dark stuff lets us know that this has worked. It also makes the kids really popular at raves and parties when they go to the middle school dances after they just kind of glow in the dark. I'm just kidding. But we have surgical tools. The question is, can we make the tools better? And when should we be using the tools, and when should we be looking for other stuff? So what can we say sort of in summary of all this? Well, I think for neurologists, for all the doctors treating children who have questions of this disease, it's important to recognize the presence that this arteriopathy, this blood vessel disease, exists in patients that have ACTA 2 in some cases. Not all cases, but some cases. And the issue is, I think by knowing this exists, you can get an earlier diagnosis, you can refer them to the right docs, we can start asking, we can figure out if there's a surgical role. Surgical revascularization, such as the synangiosis, the surgery that I showed you, is an option for patients with ACTA 2 moya-moya disease, but the risks and the benefits, at least today, are a thing that's really actively in evolution. And I think we have to increase our understanding of this as our knowledge of the disease expands. And the best way to do that is exactly what's happening right here in this room, is this collaboration between all these different fields. We've got Dr. Millis from genetics, we've got Patty from neurology, we've got all these different fields here together, and most importantly, the families and the children who are affected. And I think that collaboratively, we're going to be able to push the field forward, get some answers, and hopefully really improve the lives of people who are affected with this disease. So that's my role of the surgery part. No fancy broccoli heads, and if my accent was tough, I'm sorry. But I don't know, Patty, how you want to run this? I can take questions, or we can move on to the next speaker. You tell me. I'm good if you want to pull.
I think we can do a couple questions. Let's do a couple questions now about this, and then move on to the rehab and the eye. And I think that is going to take us maybe to extend our timeline, probably 15 minutes from what we were expecting to do. But we started like 20 minutes. Questions?
You didn't mention thrombolysis. Is there a place for that in So thrombolysis is a blood passing medication to open up if you're having a stroke. We, in children, we do not know the safety of this. We just about to publish the largest cohort between mostly German sites and some US sites that seems to be safe. In ACTA 2, we haven't seen bleeding. If I see a sudden vessel was wide open and now suddenly disappeared because we know it was wide open, we could favor you doing it, and we will adjust the dose working with the pediatric hematologist hand in hand. And it will be a conversation with the parents. It's off-label, and it does not, we don't have any experience to say that this will help kids. Have we done it in children? Yes. Has it been safe? Yes. Has it made a difference? Yes. Yeah, IV TPA, so this is a medication you give through a vein. There also another option which extends the window, that you have to be really quick. You have to be less than 3 hours to do this, right? From the time that the kids start with the symptoms to when you give the medication. 4.5, but in kids we try to be more conservative. If you put a catheter, like the ones that Ed has to put to go up, and this is something that they also do, you can go and try to get the clot, that's called mechanical thrombectomy. And that's the series of cases that we are reporting now. 70 patients treated, and 80% of them got benefit from it. They improved compared to kids that did not get treated. So that is an option. We are going to run a clinical trial across the US to see if it really is safe and who should do it. That's the best that I can tell you, not in ACTA 2. In ACTA 2, we still don't know, because putting a catheter there, and I don't know what you think, it's really scary, and not just because of the brain. You gotta go through the aorta. You gotta go through the ascending aorta. You remember the picture I showed? And all the way up in the pipes in the neck. Those are the ones that are dilated. Those are the ones that are super fragile, that when you are even doing surgery, you have to be very careful not to upset. And they can tear. So I would really guard and probably say only if it's a life-saving procedure, I will be considering that, but not in a routine basis, and not even off-label in ACTA 2. You have to be very careful with this disease of what you're trying to do and what you're going to have to struggle with when you go into the intervention.
I agree, yes. Yeah, I think the interventional radiology folks are super nervous about any sort of mechanical manipulation with the ACTA 2 patients in particular, and even the diagnostic angiograms, which are immensely important and helpful for surgery, carry and confer a higher risk than the angiograms in kids without ACTA 2 for all the reasons that Patty mentioned. So we try to avoid them unless we really, really need them. I think they're critical for surgical intervention, but you know, I think there's a lot of reservation about doing any of them otherwise unless it's a really strong reason.
Okay, so my question is, we understand that we don't know why the surgery takes on some patients and there's complications on others. And Dr. Mussolino, we know you're studying the brain portion of the disease. So question is, are you alone in doing that? Is that you alone, or are there other doctors involved? And then what is it that we or you are looking for to help figure out how we treat this portion of the disease? We have, it seems like, some good solutions for the aorta. And we're so thankful that you take on the brain portion. What are we doing to look at that to try to figure out what are the options so that we can have better choices there?
The first part is that the first doctor that has tried to start making an understanding of this was Diana. And then a lot of the images that I have access to has been from the first cohort. You remember that paper that she talks about, the 33 patients she invited me to help review? Exactly. So we have, in that cohort, we had 16 patients that had MRIs and things. We added from you guys, the Facebook and people referring patients. We added another 7 patients, so we now have 22 patients that we've seen pictures. What we need is as many people as you know that are affected. We do not get to expand our understanding until we really have systematic, good neurological and psychological evaluations, good imaging, and over time, what is happening with the disease is a matter of time to really learn what needs to be done. And I would say what is needed is that you guys participate in as many research projects, and if you know someone that you haven't heard today here, so you have the Munal clinician in the UK, you have Dr. Diana Middlewicz, we are working together, we communicate. If you know of someone else doing research, you gotta send them, push them to go to this way so we don't waste any experience, you understand? We don't wanna replicate efforts, we don't wanna get you guys tired out. We wanna try to do this in the most concentrated and efficient way possible. So that's the way I've been trying to do this, is when I hear someone is working in this, or it's like, hey, here is a group of people that is been working and trying to get together. And it was Ellen Regalado, the point person, so we need the point person to go back. And it has been working like that. So what do we need? Everybody that has images and any other medical records and any other imaging because it's multisystemic disease to really participate in research. Sign consent. These are consent processes. And then you sign consent and you share your things with the research community. The way our protocols are working is that we can collaborate and transfer the materials from one institution to another one. So there are no really boundaries on this. So just make sure that they're working together. And if you hear someone is working, just put them in contact with Diana. Okay? So that's the way I think to not dilute the effort.
A couple of things. So appreciate the presentation. When not just you, whoever's doing surgical procedures, when you find a patient with active vascular disease versus one with non, what do you find in terms of their conditions during surgery of their blood vessels? Do you find something dramatically different, or generally looking pretty much the same?
So the question is, the blood vessels look different. What do I find at surgery? I would comment that the general anatomy is pretty much the same. I do think that the brain tends to have a slightly different appearance on the surface of those blood vessels, like I showed you during the surgical video. I'm not sure what that means clinically, but I will say that technically the surgery seems to be very, very similar. The two things that I think are different, which I think we need to get better at doing, are understanding why the surgery works on some and not on the others. We're about to publish a trial of so-called regular moya-moya patients, where we do urine tests on patients to look for chemicals that are those fertilizers that stimulate blood growth. And one thing I'm interested in doing is, if we can get large enough numbers, looking at the levels of these, what we call angiogenic factors, these blood vessel fertilizers, in active 2 patients. And maybe we can understand why some of them grow really good blood vessels and other ones don't. The other thing I will comment on is it seems that the active 2 patients are incredibly fragile post-operatively or perioperatively in their risk of getting strokes. And I think that part of that reason is when you look at so-called regular moya-moya, like the pictures I showed you, the disease is over a long segment of artery. And I think that the flow becomes more normalized over a long skinny segment. The difference in moya-moya with active 2, I think, is that you have that choke point, as you saw in the pictures, where it's this big fat artery that comes up and it goes from 10 lanes down to 1 almost instantaneously. And I think that makes subtle changes in blood pressure a lot quicker. Just like if you merge the several lanes over a long period of time, it's easier to do that in regular moya-moya. I think it's a lot harder in active 2. I think that's why in the perioperative period, little changes in blood pressure with anesthesia, with vomiting. One of the saddest cases I had was a delightful little girl who was great during the surgery, and the next day threw up, and with that blood pressure change, we think that caused these terrible strokes. So I think those are some of the differences that we see, not so much with my eyes, but with the chemical composition of the kids and with the way their flow is regulated by the unique anatomy of the active 2 folks.
The way it was kind of explained to us in terms of why Sal's got blood clots was because going from the aneurysm down to the normal sized blood vessel, you're going from a laminar flow to a turbulent flow,
Exactly.
and creating the blood clots.
Yep.
But with that said, he's had a number of angioplasties to open up those blood clots under each arm. But are you saying there's a risk because of the condition, potential condition of his vascular system, that this could be more of a concern?
So yeah, I think what I'm saying is that in the brain, not another part, I would defer that to the other smart folks in the room, but specifically for the brain, I do think that this sort of what's called focal stenosis, the sudden change from big fat to little skinny, makes that funny flow, like you mentioned, that laminar to turbulent flow. And I think that's a unique difference about the active 2 kids that put them at greater risk for sudden changes in blood pressure, that differentiate them, I think, a little bit from the so-called regular moya-moya kids. We have sort of a long tapering over a bigger segment, where that laminar flow can smooth out a little longer. So I do think that's a physical difference, and that may also be why they don't have this sort of sudden, sort of gradual changes over time that some of the other moiety do.
So I have a couple questions. So that's what we found in our original publication on the cerebral vascular disease, that half the kids did not do well through the surgery, and actually pretty severe complications, half of them did okay. And may have benefited from it. But where do you stand as a surgeon? If you can't tell which way they're gonna go, we're told we do no harm.
Right.
So what's your thought process there? I mean, I'm pushing,
Yeah.
I'm sorry to do this.
No,
to you,
this is a
but I
fair
think
question, and
This comes up over and over again, and we don't,
I have a clinical, if you are having a kid that is stroking small areas of the brain and repetitively doing that, despite all your maximized medical treatment, you may have to take a risk in a way, because we know what's continuing to happen. When you just prove that a stroke is happening, it will happen again, and TIAs are like, in some of these kids, there's a TIA every week, every 5 days. That tells us how tenuous the system is. That might push you more towards the surgery, because we are kind of running out of time. Ideally, we want to do it before any stroke happens. He always talks about the brain has to be thirsty enough to really get the vessels to take. So you need to have hypoperfusion. So there is imaging that we do, which is perfusion imaging, that can be used to do that. And we're working on doing near infrared, not to do MRIs and put them under sedation, to get some data out of that. And see if we can say, or you guys heard about TCDs, the transcranial? We do this in every kid that we follow every 6 months. And we also do the MRIs of the brain whenever they get in. So I train and we teach every family to play MRI game since they are 2 or 3 years of age. That means putting the kid in a box the size of the box, of the head. And then slamming things and doing it for a game, not you're gonna go to them right now. But we can train them.
Same thing.
With the, yes, we do the sickle cell, so we train also them to play with something in the thing. And I can, in the room here are kids that have been doing this since they are 4 years of age, and they do it well. And then we have some changes there. And the cognitive, you remember I said neurocognitive testing? Sometimes what picks it up, they're losing attention, they're really declining in school instead of improving. That's when you wanna maybe take a pick at the brain with an MR perfusion, and then take a pick with the vessels and discuss, is it the right timing to do the surgery? I think it has to do with symptoms. You have to get your hand full, like this guy needs help.
Yeah. So I would say from a very practical standpoint, historically, we've always tried to treat white patients as early as possible. So we know when the disease is there, we know it's going to progress in most cases, and they're safer to operate on when they're not symptomatic. And if they're hungry enough by imaging, that's our clue, that's our biomarker for surgery. What's different with ACA2 patients is they're much higher surgical risk candidates, so we're less likely to treat them if they're asymptomatic, because I think we've been hurt by that. The problem is if you wait too long, they get too sick and they don't tolerate surgery. And what we're doing now, I think, is Patty and I are sort of finding that very, very narrow window of you're symptomatic, you've got some symptoms or problems, but you're not so sick that you can't tolerate surgery. It's a much narrower window than what we've had before. And we're limiting surgery, at least I am, to symptomatic patients that are radiographically evident disease, but not so sick they can't operate. What I'm hoping to do is, with a combination of angiogenic biomarkers and imaging findings, extend that window back a little bit so we can figure out the good candidates earlier, when maybe they're a little safer, but not when they're so sick that they can't tolerate surgery. So that's the practical.
I still have another question.
Okay.
Ready? So they don't form collateral vessels. So that tells you right away they don't grow vessels. Even if they're hypoxic, they're not growing the vessels to the same extent as Moya patient. So I was surprised, the beautiful images showing that there was actually blood vessels.
That's from that's in the new paper.
Yeah.
That's the one that we put in the
Yeah,
paper.
yeah. But at the same time, I think we need to look carefully to see what happens to those vessels over time, because it wouldn't surprise me if they actually comes off
So,
rapidly too.
so I have a theory about this, and my theory is that we've seen this in other Moya Moya folks, that traditionally, because it's a long, slow narrowing over time, it gives the brain the ability to grow. Oh, gracious. It gives them the time to grow blood. This is my cheating answer. Gives the brain chances to grow over time. The difference with ACTA2 is I think when kids are at their baseline, they're probably okay. So I don't think the brain is as ischemic at moment to moment. I think Moya Moya is just like you're choking the neck a little bit, you know, with non-ACTA2 Moya Moya. They've got this chronic ischemia where they're running at 80% instead of 100%. And that's what stimulates angiogenic. In contrast, I think with ACTA2, it's a lot more episodic, just like the laminar flow you talked about, where maybe most of the day they're totally fine, their brain's getting that flow through there, and there's a sudden change. And because it's intermittent stops, like someone just puts a pillow over your head and takes it off, you're not going to have that chronic ischemia that causes the desire for growth or collapse. I think that's the difference. And then it gets so bad.
But just one note, it looks like the mouse model, actually, they do grow the vessels, they just get closed down.
Yeah.
So that would be a completely different story.
True.
Anyway.
I just have a comment.
Yeah.
So
My daughter's 10 now, but
she had the surgery when she was 6,
and it's been very
very successful for us. And if for any reason you guys wanna, you know, look at her and follow what she's done, we're more than welcome. Yeah, or you're more than welcome to do that. So, but it was successful for us, and we saw change. So, yeah.
I just have one quick question. Last year, my daughter had a stroke, and we were referred to you. You said you didn't want to touch it yet because you still had to do some more research on her situation. This was last March. Has there been any change, or have you gotten any more research from then until?
So the short answer is probably not a ton, because we haven't had a lot more data to work on, and I'm hoping to sort of get some of that from our, discussions today. Be happy to look at the pictures if you want to send them in again if there's new ones to see. But the short answer is not a whole lot different from a year ago, and as I've shown you here with the data, that's one of the reasons we're trying to play it safe for now until we know better what to do.
So I have a quick question that, I think will hopefully benefit everybody, but is there, other than yourself, who are the other doctors? Like, we're here in Boston, you are obviously associated with one of the best hospitals in the world. Where else is this, are you the only one doing the surgery, or where else is this surgery, available? How would you guide people in this room that are from other parts of the country or in the world, where to explore this?
So there's a lot of great surgeons out there. I think Mike Lawton, who used to be at UCSF and is now at the Barrow, is a surgeon who's got great vascular experience. I can give you a list as long as your arm, but there are very few, I think, that see a lot of Moya Moya in numbers. Stanford has some experience with Moya Moya as well. Sorry? Not as much, at least but with bypass, but there's a good team at Great Ormond Street over in Greg James over in London. But to be frank, for a lot of these super rare things, if it's sort of a one-time surgery, we often recommend going to where the folks do it the most. And I've referred patients for other conditions, certain types of brain tumors, to other places around the country because, frankly, you want the whole team there. And so those are some names, but I would also suggest that sometimes travel is the best thing for these things.
So how many ACTA2 patients have you seen or performed the surgery on yourself?
So we were just talking that, we had 2 we sent to Patty, and I think we've had 3 more, after that. So it's pretty rare, and there's only 13 reported in the world, so there's not a lot. We've done about 1,000 Moya Moya operations, so we have the biggest overall Moya Moya experience in the country for children. And that's where that sort of comes to the same, but I don't think anybody has any big numbers for ACTA2, and anyone who does, I'm glad to hear them, but it's a pretty rare
So
condition.
the Cleveland Clinic is claiming that they've done quite a few cases and that they've been uniformly successful in what they're
With
doing.
the ACTA2 as well?
Yeah, but they haven't gotten the actual numbers, but that's what they're saying to patients that I referred there for
And
follow-up.
I want to see the MRIs, because
Yeah.
there are things that are silent, that are having hits to the brain, that are counting. They do count for the development, they do count for function. So this is what we need. You guys hear of any family that has had any surgery or anything, just put it in contact with us, so we can gather the data, we can invite them to participate in the research, and then we can try to answer
Or
these
at the
questions.
very least, ask them to publish their data. so we can look at it.
Yeah.
Yeah, that's the hard thing, 'cause you meet people in meetings, you talk with
Yeah,
them,
they
and they
tell
kind of
you.
say, oh, I did this, I did that, and this is where the transparency of actually, showing the numbers and publishing and stuff, I think is,
And I don't even know what surgical procedure they do.
you can say
They
anything,
do
until it's
accurate.
published, it ain't real.
Yeah.
Yeah.